Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
Great. Just finished a big clinic. Not as big as in the past, but a still pretty busy one. I feel like clinic seems to be like a sponge. Like it just kind of takes up as much time as you give it. There are some days where I'm seeing a ton more patients than I normally do. It still ends on around the same time. And then there are days where I'm seeing a lesser number, probably the one I'm actually templated to see. And it still seems to end at the same time.
That is an interesting point, a really important one, and we're going to take a deep dive on some clinic efficiency tips. And I think there's a point to be made exactly based on what you said.
Oh, I hope that you can educate me. I've always learned so much from you about clinic efficiency, so maybe I'm in need of a refresher. So yeah, today we'll go through clinic efficiencies. I think we'll talk a little bit technical aspects of a case as it pertains to radial tunnel, which you volunteered that topic,
How
just putting
about
it
it?
on the record. But yeah, I think it'll be a fun episode, and we're getting towards the end of the year, and I think people are always looking for new things to learn at a reflective time of the year.
For sure. And I think the beauty of this topic of clinic efficiency, which we don't claim to have all the answers, but we both see a fair number of patients and seem to keep most of them happy based on a lot of different metrics, including Press Ganey. So maybe we can share something that's useful. I was speaking with Sarah, our fellow, and we had a little break despite the craziness of the day, and it was kind of fun talking about what we're doing right and what we can do better.
Just out of curiosity, how much time are you scheduled for in your quote lunch break?
Oh, yeah, I do have a lunch break. So I start at 7 a.m. and my last patient's at 4 p.m. and I have a 1 hour lunch break. That lunch break ends up being probably 40 minutes total. I'm usually done by 12:20, and between 12:20 and 12:45 I dictate, and then I usually take 15 minutes to get out of the clinic to clear my head and come back for 1 o'clock. What about you?
Wait, so our at this point, we are recording. It's 4:38 p.m. after a clinic day. Are your notes all done?
Yes. I saw
Wow.
58. Notes are all done. Actually, that's not true. A couple didn't show, but 58 were scheduled. A few didn't show. Notes are all done. What about
So
you?
I guess this is a relic of when we would consistently have conference in person when I first started, and my first because we have our Monday morning hand conference. My first patient slot is at 7:40, so I can commute from the main campus to come down here to the satellite center. I go from 7:40 to 11:50. I start back up at 12:30, and I go until 3. And I'm done at 3. Like my last patient slot's at 3, which allows me the occasional indulgence of going to do a case at the end of the day or to go and do a case with a partner. We have a one of our shoulder and elbow partners operates here on Mondays, so sometimes we'll tag team cases at the end of the day. I think there's probably ways to make my schedule better, but I just haven't. There's been some inertia there, and it seems to work out so far pretty well.
I think you. And what's your average number of patients that you see?
So I think I'm templated low 50s. I tend to see somewhere between 55 and 60, and then there ends up being the crazy days. I haven't gotten to the. This is going to sound insane to those that are listening overseas, I think, but I haven't gotten to the magic number of 70, although we've tickled that number several times.
It does sound crazy. It sounds crazy to me, and I know there's hand surgeons and hopefully listeners that do see that many patients. And I really honestly believe if I see 55, 58 patients, I can have every one of them who was destined to leave happy. I can have them all leave happy, and leave feeling as though maybe they didn't get 100% of the time they expected, but they got enough time. I think when I get above 60, it's hard to do that. And we all know that one challenging patient, and I don't mean that necessarily in a negative way, can throw everything off.
Yeah, and I think that, occasionally there are times I've tried to build in like slots for more complex nerve patients, which a lot of them go to the main campus, but occasionally they'll slide in here. Sometimes there are patients who like there'll be a person who's referred as, numbness and tingling actually ends up being a brachial plexus injury, which obviously can derail the clinic, but you do the best you can to keep everybody happy, give people the time that is appropriate. Using our new AI tool for clinic notes, I have noticed that, it there are visits where I don't feel rushed at all. I think everything goes really smoothly. I answer questions, we do a thorough assessment, and I'm not in the room that long, which is probably why things average out okay.
I think that's right. And maybe that's our first pearl, which we've said before and we will emphasize again. It's not universal amongst our faculty who have had access to the AI tool we use. We use a Bridge AI at Washington University, and I use DAX Copilot, which is the Microsoft old Dragon tool at the Shriners. They're both excellent, and there is no doubt in my mind that had I not used that today in clinic, I would still be dictating for sure. So it is a complete game changer. It de-stresses me. It creates a pretty good note. I edit every single one of them. And it also makes sure that I don't make anything up. I don't make up any fiction because it gives me the baseline that then I say, oh, I absolutely remember that patient, remember what we talked about, what we did. So that's the first pearl. And if you were a listener, whether you were a therapist, whether you were a student, whether you're whatever, um, getting access to these tools, which are not universally available, even here, try to get access.
Yeah, I know that some of our therapy colleagues have been introducing it into their practice too, both in and out of the university setting. I find it there are some challenges with it. By and large, I like overall, it does make my life easier, but it's clearly not a panacea, and you cannot let it run off on its own. I found it, even if I somewhat try to be explicit with laterality, it's challenging because a lot of times there are things that patients come in, they want to discuss a different thing on the other side, and sometimes it can be a little bit challenging to have the verbal cues that will nudge a bridge to actually assign laterality correctly. Same thing with physical exam things. I try to verbalize some physical exam things without making the interaction too awkward, like I'm specifically talking to the ether or my phone in this case. So I still end up doing some dictation of exam, like either after I left the room or obviously on the tail end. How do you approach doing the physical exam and also laterality?
I think both of those are excellent points. I don't know that I have anything to add about laterality, just trying to say it repeatedly, awkwardly in the room. And physical exam, I always make the little joke about I'm going to talk to my phone now. I'm going to sit, this is going to sound a little awkward, but I'm going to be very specific about what I'm doing on your exam. And nonetheless, I will edit the exam. As I think we've mentioned previously, and it's worth mentioning again, I now dictate before I walk in the room, especially if it's a post-op patient. I say exactly when and what we did. And after I leave the room, I may add some physical exam details or whatever. And then I get on the computer and enter my note and optimize it. So no huge tips in that regard.
Have you named your Abridge AI scribe?
I have not. Should I have?
I don't know. I have a name for mine. As I vent my frustrations about said scribe, I find it's more easier for me to assign the name. And then somebody else asked me, "Do you think anybody else has named their Abridge AI scribe?" So maybe it's just me.
As far as I know, it's just you. Is there a story behind the name or just you got a
It
name?
just rolled off the tongue. Allie and I sometimes get along very well. Allie and I sometimes don't get along very well. But
It's really funny. I
just
like
like
it.
any relationship in clinic. So,
Yeah, yeah. Um, well, why don't we thank our sponsors?
so the upper hand is sponsored by practicelink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand. So
What were these
AI,
clinical efficiency pearls that you shared with Sarah, our wonderful fellow?
well, some of it is, we have the luxury of having our core person. And Sarah and I talked about how important that person is. So, a nurse, a medical assistant, an athletic trainer, whoever that is, that person is so critical for your practice. So, and I think we've talked about that, and you know that. We all know that. If you have a choice, and most of us do, then aligning with that person, having a similar sort of approach to life and clinic is incredibly helpful. Um, and that person will make you better, will make you look better, hopefully. Where I'm going with this, and I'd love your comments on that, but where I'm going with this is sometimes we have nurses or MAs who join us, and they're not always exactly aligned. And so keeping them on the same mindset, same framework, moving in the same speed is really important. And so we talked about that a little bit, but having the core nurse or medical assistant be the right person is just it's the most important decision you'll ever make.
Yeah, and we touched on that. I think it's probably 5 or 6 months ago, on an episode where people, graduating fellows were looking for advice. And I agree with you entirely. If you have control over who that person is, I think it's something that you can probably tell from an interview, although sometimes it's hard to glean that. But it is a certain approach, a certain energy. I think you understanding, kind of their workflow, and then them understanding how they can best work together. I think that is critical. Yeah, the having that extra person in clinic can be useful, and I think I've struggled to figure out how to best utilize somebody who doesn't exactly kind of work in the same tempo that I do, and still make them feel like they are contributing to the team and that they are, not a negative in a sense. Because I think sometimes if you rely on everybody to know the cadence that you work at, if you're not specifically verbalizing that to them, they may feel either lost or nobody's kind of including them.
Yeah, I think that's really good. Um, so talk about some of the pros that you have when you walk into a room. You know, it's for most for I don't know what the percentage is. Half the time, I know exactly what's going on within 10 seconds, or whoever's seen the patient before me, including my nurse or a resident or fellow or the therapist, have tipped me off enough that I know exactly what's going on. So the goal is not necessarily for many patients making the right diagnosis. It's both coming up with the right treatment plan for the patient. It's also making the patient feel like and appreciate that they've been given the time that they need. So they're not always aligned goals. So how do you make the patient feel heard, appreciated, um, in a direct way, in a time sensitive way?
Yeah, I think that it's a challenge. I think that if we take kind of the complex nerve stuff that I do outside, and we're just talking about, bread and butter general hand, I think it's trying to get to know, ask them some questions that make them feel like what they are prioritizing in terms of goals and return to function, et cetera, are not only heard but considered as we create a treatment plan. Um, I remember there was one point when a former fellow who is now a decorated hand surgeon at the University of Pennsylvania, Dr. Andrew Sobel. I remember I was relatively early on when he was one of our fellows, and I remember him being in clinic, and had just come off a year rotation, and I was like, "Hey, how is this different than Dr. Goldfarb's clinic?" He's like, "Well, you guys use the fellows differently." And I thought about that, and I tried to think about how you would use the fellows, not use in the wrong, not in a negative way, but like how you incorporate, what having a fellow in clinic versus how I was. I think at that point I was still basically repeating the entire assessment that the fellow had just done, and not piggybacking off of what the fellow had done. Now, clearly, there are moments where you're still trying to feel out kind of what they know, what their style is, and how it may jive with yours. But I think I've moved more towards complementing the assessment that the fellow has done.
I think that's really important. And for most, I mean, for all, I would say maybe every patient, that's good enough as long as you quickly get the sense that the fellow's assessment is the right one, and B, you can do that in a way. And again, every patient has different needs. How do you convey empathy? Because I am convinced that, and I don't mean that in a false way. It's not like pulling the wool over someone's eyes, but how do you appropriately convey empathy, which seems to me to be the key objective in this brief interaction with a patient? Show them that you care, show them that you heard what they have said. Any tips on that?
Yeah, I'm probably not the best person at that, to be honest with you. I know that I think my clinic style, personality wise, from what I've been told by others, tends to be a lot like yours, which are on one side of the spectrum as some of our partners. But I remember anybody who's met or knows both Ryan Calfee and Marty Boyer will see that they are probably on a different personality side of the spectrum than you and I are, Chuck. I think that when I came out of training, I tried to, and I don't want this to come across in the wrong way. I tried to be a little more Calfee-ish than I actually am, like as a person.
You mean kind?
Yeah, just outwardly gushing, like, like always like upbeat and smiling and and that works really well for him because that is him. And then I realized I'm not him. Like I can't ever like, because you come out of training and you want to emulate your mentors so badly. And for me, it was settling and finding who I am and how I talk to people. And how I talk to people is not for everybody. I try to empathize the best I can. I try to lock into what, they value and what they want to do and how we can get them towards their goals. But I know for sure that my personality is not for everybody, and I've seen that in my Press Ganey reviews because it comes out. But if I am not the one for them, I've stopped feeling bad about that because we have plenty of other partners who are incredibly skilled both in the clinic and in the OR that might be a better personality match.
Yeah, that's really important. I mean, well, I'll start by saying that you and I now, and I would say both of us have a little bit of a built-in advantage as more senior or established people do. People come to us with an expectation, and that helps us. We are given the benefit of the doubt. And I certainly know that I am based on my age and tenure and all that kind of stuff. And I think you are as well. And that helps for sure for the medical students or the residents or fellows who are listening, there are a couple of things that get repeated that are real. Always sit. It doesn't matter if you're in there for 30 seconds. Always sit.
Hmm.
Always touch the patient every single time. Doesn't matter if it's just a tap, but touch the patient. Do some type of exam. And then your eyes speak volumes. The kind of eye, the connection, the visual connection, and patients can read you. And it doesn't matter if I'm in there for 30 seconds or 1 minute. I hope that I convey really honest empathy, because that's my goal, and it's always real. And then other times you have to kick it into a different gear if things aren't going perfectly. If you're frustrated, you or the patient is frustrated with an outcome, then you turn off the clock and you really focus on how do I express my opinions and help the patient know that this is going to be okay one way or another.
Completely agree with that, with all those, especially the last point. I think that for better or worse, I kind of make a conscious effort to lower my stool, the sitting stool, and I kind of make myself look a little smaller, which I think helps just with that relationship if you're not looking down on them, especially obviously if you're standing up. But with the exception of when I give my TOS kind of spiel, and then all of us early in the room are like sitting up really, really big because of the whole posture thing. But I remember Marty Boyer telling me, that you don't want to look down on patients like physically because that changes the dynamics of that interaction entirely. And then I think the eye contact thing is really important. I think humorously, sometimes there are patients that out eye contact me, which then it starts to fatigue me. So it's like a staring contest. But overall, I mean, I try to connect. I mean, because it's like, you try to tell people that are not in medicine and, what our clinic days are like. And like the surgery days are actually, I think, by and large, just a little more relaxing because clinic is like having 60 back-to-back meetings, just where you have to be on because that's their only interaction with you in person. And if you don't give that energy, which is challenging to do, whether you're seeing 30 people a day or 70 people a day, it's challenging to always be on, which is why I feel so exhausted after clinic.
No, that's exactly right. One could state that true extroverts may be better suited for that high pace. And I don't think it matters. I mean, I would not call myself a true extrovert. I'm tired too, for sure. And then, I go home and don't want to talk, but, yeah.
Or you could record a podcast episode.
Or you could record a podcast. That's right. And then a couple other things I think about. I think about daily. You have to walk into the room, even if you know it's going to be a frustrating encounter. You have to walk into the room, with a positive approach. Challenging patients have problems too. Um, it doesn't matter what the patient looks like, sounds like, what their history may have been. You have to give every patient the benefit of the doubt and really try to identify the problem. And again, as you mentioned earlier, we are not going to connect with every single patient, and understanding that and not feeling bad about that is great. And we're also not going to make the diagnosis on every single patient. And I think we all do a good job of sharing patients when the goal is only to make the patient better. And if I can't do it, maybe you can, or maybe Marty or Ryan can. And I have a low threshold for offering that.
Yeah, no, I think I can tell the patients that I connect with, both on a personality level as well as the patients that fit my skill set, and have had no qualms about referring to, Ryan and Marty, Lindley, David, Jason, and now David Wright. So there are, I think, things that I'm better at, and as I've become, further on in practice, I'm just more okay with that. It's just like, I think there are a lot of times where it's very hard to either think to yourself or to verbalize that I don't know with patients, and I think that becomes a little bit easier. And there's a way to handle that in a way where you can still make the patient feel like you can help them, even if you don't in that moment know what the issue is. The biggest difference, I think, when you're seeing patients as a fellow is that, or a resident, is that you get to come out of the room. You get to collect your thoughts because typically the faculty is somewhere else. You get to, do a little research, quick search. I'm sure it's all, open AI now and, open evidence and gather thoughts. Whereas as an attending, you can go quickly between room to room and just you're throwing a curveball in every room, or you get a strike down the line, and it's easy. But you just don't have that moment to pause, collect your thoughts, etc. all the time. And I think that decision making in front of a patient to yourself can be one of the more challenging things to master as you're coming out.
Yeah, really well said. And let's be honest, there are different ways to buy time. You can buy time by letting the patient know you want to talk to a partner. And again, that gets easier as you get more seasoned. It feels less awkward. You can buy time by ordering a test. Now, I hope that none of us order an inappropriate test to buy time, but there's value in that. And then potentially bringing the patient back for a repeat exam, correlate the test results with the exam. Those are valuable tools done correctly.
Yes, exactly. And I think that maybe we can close before we move to the clinical topic with what are the ways that in which you have kind of shaped how your team does things like chart prep in order to make the encounter go as smoothly as possible for you and the patient.
Oh, that's interesting. I've never talked to my team about how they prep the chart. Uh, I guess unless, well, you probably mean this. So when I dictate on a patient that I've seen before, I absolutely have in the assessment plan what I want for the next visit, which is usually pretty easy. X-rays, pull up the results from whatever testing. Um, and then ultimately, I defer to my team as far as what they feel we need. So again, they may take a 1 or 2 sentence history, an update. They may know that the patient wants an injection, but I'm guessing by your question that you do specific things, which I would love to hear.
Yeah, I've become a little more comfortable kind of saying what's going to help me work more efficiently. So yeah, to your first point, I mean, at the end of every clinic note, I try. This is harder with my friend Allie, my AI scribe, but to make sure that the last line says, follow up in 6 weeks with either repeat clinical assessment, which is just Roomum, or fluoroscan images, or fluoroscan images out of cast, or formal X-rays, scaphoid series of the right wrist out of cast, so that it's very clear exactly what I want. Because I don't like sending people back and forth as much as we can. One thing that's helped is just making sure, and this seems silly, but just making sure that the date of surgery is just on the actual sheet that I take into the room, and ideally the surgery that they had done, just the procedure names. It just helps me kind of move through the visit a little bit faster rather than having the extra clicks to open things up, either right before I walk into the room or when I'm in the room. And then for the folks that are writing notes, just leave breadcrumbs for yourself in your notes. Figure out ways that you can say things that in ways that are appropriate to have in a chart in an environment where every patient and every referring physician has access to the chart, so that you can kind of code things for yourself. And then the last thing I do is that for nerve study patients, actually, and I hate to say this is awful for the environment, I ask my team to print out the nerve study because
Oh,
it helps me as I'm in the room, not fumbling on the computer. If there's anything, I can look at it quickly as I'm walking into the room, and I have it as a resource, and I actually use that to kind of show things to patients at times, which has been useful. Again, not great for the environment, fully understand, but I find it awkward and clumsy to log into the computer and to pull up stuff if I need to show it to a patient.
I like that. I do ask the team to log into the computer, and I usually just pull them up on the machine, but I totally get that. Um, you know, if there's patients listening, forgive me. I don't review the chart before I walk into every patient's room, and I think it can be physically impossible with a big clinic to do that. And thankfully, I don't need to. I don't have the world's greatest memory, but I remember a lot, and I do hit the chart before I walk in the room when I need to, and bolster my memory and hit the key points. And I think that's an interesting thing because when we had paper charts, and I know you don't remember that, you could flip through it as you're walking in the room, but now you either do it or you don't do it. Um, and that what you said earlier is really important. On that sheet which we walk into the room with, there is a surgery date or a last visit info. That's super helpful.
Yeah, no, and I've tried to leave like little things about the plan for the next visit in the note in which our team when they do the chart prep, particularly when the athletic trainer I'm working with now, Hannah, she's awesome at like putting in like little things like here's what you're thinking about doing at this visit. And then obviously I think there are times where as the team is rooming patients, they can kind of say, like, oh, were you guys thinking about doing an injection today, or how's your finger doing? And knowing that like if the patient is prepped emotionally for an injection, I love having the injection in the room, which can make things much straightforward and make you much more efficient.
Yeah, yeah, I love that. Before I share a case with you, um, let's thank our other sponsor. The Upper Hand is sponsored by Checkpoint Surgical, delivering innovative solutions for peripheral nerve surgery. I'll stop there.
Checkpoint is excited to announce the new Targeted Muscle Reinnervation Manual for TMR. TMR, a modern technique for actively treating transected nerve endings, authored by doctors Sunishka Wimalawansa and Ian Valerio. To pre-order your copy, visit the resources section on checkpointsurgical.com.
I am really happy I asked you to do that section.
I knew you would.
Um, awesome. So, yeah, a little case. We're doing this feels a little backwards. We usually start with the case, but I like this. So, I have a surgery coming up. I haven't done it yet. It is a 54-year-old right-hand dominant male whose forearm was crushed at work, so a workers' compensation injury, with between a forklift and a box. And this was like 3 months ago. And there weren't lacerations or anything, but it did swell a lot, and he's been left with some pain, which is both vague and can be reproduced on exam, which I can talk about. He doesn't have frank numbness, but he does have intermittent numbness that comes and goes in the vague median nerve distribution. So on exam, he has radial tunnel pain and he has pain over the pronator, which again, maybe we can talk about that. But the real question is if those are your two diagnoses, and I also think he has carpal tunnel, so I'm going to do a carpal tunnel release. But if those are your two primary diagnoses, technically, what's the best way to approach the pronator and the radial tunnel? Single incision, two incisions, dorsal? Love your thoughts.
So I guess just for completeness of the case, assuming no fractures
No fractures
and elbow joint motion is okay,
is okay.
forearm motion's okay,
Yep.
and the skin is okay.
Yeah, absolutely.
Okay. So I guess if we've made the decision to do those surgeries, I think that probably could do this all from an anterolateral approach or an anterior approach. I probably would favor anterior because I routinely will use an anterior approach to the radial tunnel as part of the setup for a median to radial nerve transfer or vice versa, radial to median. And when you're doing the median to radial, you're actually decompressing the median nerve in the areas where I think that are most important, which is the lacertus and specifically the FDS arch. I'm less convinced that the pronator muscle belly itself is a true point of compression over the median nerve, although I acknowledge that that is what is classically taught and is taught still by many. So to summarize, I probably would just go straight anterior.
So talk to me about your incision. Do you start at the antecubital crease, somewhere between where you expect the median nerve and the radial nerve to be, and just longitudinally heading distally?
So I guess it depends if you're doing if you're going to do a superficial radial nerve decompression too, that would make the distal tail of the incision a little bit longer. I do follow the classic Dr. McKinnon approach to this, to making like a curvilinear incision. And the way to fashion that curvilinear incision obviously depends on whether it's a left or a right. But for me, just know that the part that is most lateral is going to be the start of your approach, and then you'll concavely come down where the between the median and the radial nerve, and then you'll come back up. And if you want, in order to get like a more an easier approach to get to a different window for your radial tunnel release, and then you can come back down with your if you needed to get to the superficial radial nerve. So again, the more proximal part needs to be lateral so that you can get access to the radial nerve proper as it enters the forearm as well. But a lot of times you can get to all of that through that type of approach.
And are you a user of a clip applier? Do you tie off vessels? What's your approach?
I think it depends. If I know I'm going to be ligating a lot of vessels, like for a radial tunnel release, I just open a clip applier. If I think, for a cubital tunnel, I'm not ulnar nerve transposition, I'm not tying off a lot of vessels, and I'm not ligating a lot of vessels. So I think it's actually important for our trainees to do some tying. So I get out the 3/0 silk ties. And I think that that is an efficient way without spending too much time. But if we're going to be, but there's a potential for clipping off, ligating a lot of things, I just use the small and medium Liga clips. How about you?
Yeah, I've not used Lego clips. I think for this upcoming case, I will for the reasons you say. It does save a lot of time, but a couple of vessels when I have to tie them off, then like you, I like to do it, and I like the residents and fellows to do it. So let's say we start with our median nerve. I assume you begin just medial to the biceps and release your lucertus as a starting point. And do you go find the median nerve there and trace it distally?
I do. I think it's easiest to find it there. I think the tricky part is that, finding the median nerve when you're coming from essentially straight anterior can be harder than you think. Because you think about the anatomy books and everybody kind of has it as like a 2D kind of flat representation where the flexor pronator mass and then the median nerve and the artery are all kind of sitting there. But it's not it. Like the median nerve actually kind of comes on the undersurface of the flexor pronator mass, which can be challenging to find. And it's a little bit more volar and an anterior if you are a little more proximal before it takes that kind of turn. So finding that the Lacertus, I think, is helpful. And then going underneath. How do you approach it?
Yeah, similarly, obviously, if you get down to the brachialis, you've missed it. I think you're right. I think the more proximal, the more likely you are to find it right on top of the muscle. As you get more distally, it's sort of heading up to travel between the two heads of the pronator, which, I agree. In large part, they don't worry me too much. I guess dynamically they could apply compression, but the goal is to make sure there's nothing there and to get that FDS arch.
Yeah, the FDS arch I think is huge. I mean, it's a pretty clear and distinct structure. I think that if, this is not your case, but for those that are listening, if you see somebody who just has not responded well to a carpal tunnel treatment, and is still having issues, just check them up there because on exam, just kind of pushing right in that spot where you'd expect the FDS arch can oftentimes elicit a lot of distal paresthesias. And just anecdotally, I found that to be in people with larger forearms who tend to be people with kind of more laboring kind of manual jobs or just have, are very muscular.
Yeah, I love that. And so do that and then head a little more radially. And I love how you comment about the proximal aspect of your incision being more radially, which gives you access proximal to the radiocapitellar joint where you have the radial nerve proper before it bifurcates or trifurcates, depending on muscular branches. But I love finding things there, using the clip applier, and then tracing the nerve more distally.
Yeah, and I think that, honestly, you've already got your exposure distally. I think to make your life easier, just raising up the brachioradialis and finding your superficial radial nerve, while it seems that you're doing a little more dissection that may or may not be necessary based on the case, I think it just moves you along so much faster. And then as I'm walking in, I can then see my ECRB branches, and then you get into all of the branches of the leash of Henry, and the vena comitatantes, which turns into just get everything exposed safely, clip everything efficiently, and then you're staring at your leading edge of your supinator, which I think that is honestly probably the most compressive point out of all the named points of compression of the posterior interosseous nerve in the radial tunnel.
Yeah, I would argue pretty strongly that, well, first of all, some may be arguing that what the heck is Goldfarb doing? He's operating on two potentially non-existent diagnoses in the same patient. I swear these are uncommon surgeries, but I think in this patient it makes sense. But I would say just like the FDS is, the fibrous leading edge of the FDS is the key to pronator. I would argue strongly that the same thing for the supinator, that band of fascia, the arcata froge, is incredibly important, and that I think is where the money is.
And that's why I think that there are a lot of different ways to do the approaches, which are all basically named after their relationship to the brachioradialis. I like the anterior approach, which is anterior to the BR, which is what we just described, because I get maximum control over the leash. I get to very clearly see the most common point of compression at the arcade, and I can release that very comfortably under direct visualization. That being said, you could go anterolateral, so just posterior to the BR, in between the BR and the ECRL, and you can go. You could even split the extensors. But theoretically, based on a paper out in New York when I was a resident, I didn't write it. One of my co-residents did. But you get the best visualization of the anterior or of the arcade from the anterior approach. The downside is that theoretically you might have a more limited visualization of the distal aspect of the supinator. While yes, that is a potential point of compression, I'd argue that it's usually more of the arcade, the leading edge. And if you really work at it, you can get to that distal aspect of the supinator, or you can just drop in on the other side of the BR and get it that way. So I found that to be the most reliable approach, especially if I'm working with somebody else as we're doing the dissection together. I'm a little more comfortable kind of trading use of the tenotomies if we have direct visualization of all those pesky vessels.
Yeah, that my only point of contention, which has led me to do more dorsal approaches, is that I am often treating lateral epicondylitis and radial tunnel syndrome simultaneously. And in that situation, I think it's easier to go dorsally. There is no question in my mind that the anatomy is more approachable and more beautiful from a volar approach. So I'm looking forward to this case.
Do you think that you can get a very reliable treatment of the ECRB origin from that anterior approach, or do you feel like just have a better shot at it if you're more dorsal? And then, how dorsal are you? Are we talking anterolateral or like a straight dorsal extensor splitting?
No, anterolateral brachioradialis ECRL is, but I say that with such confidence now. But as we all know, in the operating room, finding that interval sometimes is tricky, and sometimes you bluntly spread the muscle and you are looking at exactly what you need to see, and sometimes it's a little bit of a struggle. Hopefully, not too much of a struggle. And then to answer your question about the ECRB, first of all, I'm not convinced it regularly matters, and I'm certainly using the point of maximum pain an aid here, and it's almost always again the leading edge of the supinator. But I do think while it can be tricky, you can get there. But if you're really concerned about a more proximal point of compression, you have to go volar.
Yeah, absolutely. I think that's all well stated. And I think the key and the important point that you've stated is that you kind of have to do them all because you never know when you're going to need to pull these different techniques out of your bag. Be comfortable with all of them, practice a bunch of them in the lab, try to see them all in your training, and then just use your principles and go with whatever you're most comfortable with as, option A, and then be ready to do B and C as needed.
Yeah, love it. I appreciate the conversation. We don't do a lot of preoperative conversations, but I'm going to feel
That's
much better
great.
about the case.
I'm sure it was this discussion that made you feel ready, not the 85 years in the game that you have. And
Those are dog years.
one quick question: do you routinely let the tourniquet down for these cases, or do you leave it up? Because I know that we have partners that do either one.
I, well, in general, I do not let the tourniquet down. However, this is one of the cases where I do. I will absolutely let the tourniquet down. You?
Same thing. I let the tourniquet down. I think that if there are cases where I don't routinely let it down, except if there's a pesky vessel that we're having a hard time with that I just want to know. So I think everybody can sleep better. But for this one, because I know there is a pretty substantial hematoma risk, and you're working around all those pesky vessels, I just go ahead and let it down.
Yeah, absolutely. This was fun. Thank you.
This was fun. Enjoy your case. And if you're a listener and you have different ways in which you want to tell us about your clinic efficiency, would love to know that. Hopefully, you have some pearls that you can share with us that we can share with the listener audience. Or if you have pearls on radial tunnel releases and median nerve decompressions, would love to hear them. So handpodcast@gmail.com.
Thank you.